Hello, welcome to the Donor Anatomic Record Project for Tank 46 with Chris, Kirby Ann, Brandon, and Andrew. Our cadaver was a 73-year-old Caucasian female who died on August 21st, 2017. She worked as a security guard, and the cause of death provided to us was anoxic encephalopathy.
So the first source of anatomic variation that we're going to discuss today we found in the abdominal block, and that was that our cadaver had a right hemicolectomy. So our cadaver's ascending colon was absent, and the transverse colon was sectioned directly to the small intestine, and we were actually able to see where the procedure had been done. We found the staples. And so the context of our patient's hemicolectomy was unclear because we didn't find any further intestinal pathology. But some common regions that people generally have a hemicolectomy include inflammatory bowel disease, which would include Crohn's disease and ulcerative colitis, as well as polyps or potentially malignant cancerous tissue growths found in the intestine. And in addition to a hemicolectomy, we found that the donor had undergone a cholecystectomy as well as a partial hysterectomy. And so cholecystectomy is removal of the gallbladder, and it's the treatment of choice used for cholelithiasis or gallstones. But despite being a very common procedure, it has a relatively high risk of complication, between 1 and 12%. With the most common complication being injury to the common bile duct because of its proximity to the gallbladder. However, we did not find any such injury in our patient. And as for hysterectomy, hysterectomies are one of the most common procedures done for postmenopausal women. But a lot of times procedures lead to psychological disorders such as bipolar disorder because of hormonal dysfunction and the role of the ovaries and female genital tract in hormonal regulation. So as for our cadaver's liver, one of the first things that we noticed in the abdominal block was that the liver was very grossly enlarged, or that our donor had severe hepatomegaly. And then upon further microscopic examination, we found that the liver sinusoids were extensively dilated, and oftentimes such enlargement of the liver sinusoids is associated with right-sided heart failure because since the heart can't pump blood into the systemic circulation or into the pulmonary circulation rather, blood gets backed up in the liver, and that causes significant liver pathology. However, we did not note any substantial enlargement of the right side of our heart on gross examination. Okay, and another source of anatomic variation that we found was an arteriovenous graft in our cadaver's left forearm, which essentially was just a plastic tube that had been inserted into the subcutaneous tissue connecting an artery and a vein in the donor's left arm. And the presence of this AV graft does suggest that our donor was undergoing hemodialysis prior to death, and that would end up being consistent with our gross finding of severe nephrosclerosis, which we're going to discuss in just a minute. And so while these grafts are considered a common choice of treatment for all types of renal disease, they have a lot of complications involved that can include infection, thrombosis, and stenosis. And all of those things could have potentially impacted our cadaver's quality of life and led to death even.
Another source of pathology that we found in our cadaver was nephrosclerosis, which is defined as hardening of the walls of the small arteries and arterioles of the kidney. Some symptoms typically seen with nephrosclerosis include impaired vision, hematuria, which is the presence of blood in the urine, and uremia, which is the presence of excessive urea in the blood. Some treatments typically found are antihypertensive drugs to lower the blood pressure, elimination of the infection or obstruction that may be contributing to the pathology, or other measures to relieve chronic renal failure.
Slightly to the left of her umbilicus, we found a hernia. The hernia may have caused her some discomfort And things that increase intra-abdominal pressure, such as obesity or ascites, etc., can induce the risk of having a hernia. So there was nonspecific fluid as well as blood in the air spaces. The air spaces were also noted to be slightly disrupted, and there was evidence of mild emphysema. And these findings were suggestive of chronic bronchitis and pneumonia. So bronchitis is chronic when there's a cough with sputum production for at least 3 months, like a year, for 2 consecutive years. This chronic bronchitis may have hastened lung decline in our patient and reduced her quality of life, and actually may have hastened her death.
On gross examination, we found that our donor's brain had bilateral cerebral edema, as well as an apparent subarachnoid hemorrhage in the general region of her brainstem. The hemorrhage would be consistent with a hypoxic injury, which is further consistent with the diagnosis we were given. When we further inspected the brain tissue under a microscope, we found red neurons throughout the entire slide, and that's suggestive of a hemorrhagic event occurring about 12 to 24 hours prior to her death. So a subarachnoid hemorrhage is just more commonly known as a stroke. It's bleeding into the space between the arachnoid mater and the pia mater. And though the etiology of our donor's subarachnoid hemorrhage was unclear, the most common etiologies that contribute to it are rupture of an aneurysm, traumatic brain injury, and arteriovenous malformation. Risk factors that contribute to subarachnoid hemorrhage include hypertension, smoking, excessive alcohol consumption, and family history of subarachnoid hemorrhage, family history meaning a first-degree relative. And the treatment for these kinds of hemorrhages depend on the severity, which can be classified according to the Hunt and Hess scale, which we've put to the right of this slide. And the most common symptoms include headache, which patients commonly describe as quote-unquote the worst headache of their life, nausea, vomiting, neck stiffness, blurred or double vision, and loss of consciousness. If intervention occurs quickly enough and the patient survives the hemorrhagic event, treatment includes any kind of mechanism to repair the bleeding vessel. In cases of ruptured aneurysms causing the hemorrhage, you may see endovascular coiling or surgical clipping to treat it. And following immediate intervention, outpatient recovery may include medications for hypertension or any residual pains the patient may be having, most commonly including headache. If any neurological deficits present, treatment may also include physical rehabilitation and speech therapy.
So in summary, in our patient's brain, we found subarachnoid hemorrhage with bilateral cerebral edema secondary to it, as well as red neurons throughout the cerebral tissue. We think that a stroke was most likely, and it was possibly due to an aneurysm rupture or trauma. In the liver, we found severe hepatomegaly as well as large sinusoids, which are indicative of right heart failure. In the kidney, we found nephrosclerosis, which is indicative of hypertension. And in the lung, we found mild emphysema. And the condition that we think had the biggest impact on our patient and most likely led to her death was the subarachnoid hemorrhage in the brain. So the suspected cause of death. So given the gross pathology and the histologic findings of our patient, we suspect that her cause of death was the subarachnoid hemorrhage mentioned earlier, specifically the anoxic encephalopathy that occurred secondary to it. The hemorrhage was observed grossly in the region of the brainstem, with the cerebral tissue being populated by red neurons throughout, and this confirmed our suspicion of a hemorrhagic event occurring at least 12 to 24 hours prior to our patient's death. All in all, this puts us in agreement with the diagnosis that was given to us of anoxic encephalopathy. Here we have a slide of our references for you. Thank you so much for listening.